Good afternoon, ladies and gentlemen, and welcome to today's Michigan Peer Review Organizations webinar. All lines are in a listen-only mode. We will take questions at the end. There will be a live Q&A session over the phone at the end of the call. But please feel free to type your questions into the chat box throughout the presentation. Mr. Kristian will now begin.
Good afternoon, everyone, and thank you for taking the time out of your busy day to attend our January webinar land. This is the first we will have for the year 2014, so Happy New Year to everyone and welcome to our land. Just want to take care of a few announcements. Impro is now on Twitter and Facebook. You can follow us at ImproCares and like Impro on Facebook. We want you to look for our February newsletter, which is coming soon. It highlights information for providers, community partners, and resources for patients. Quarter 4 data is due today. And to request assistance in pulling data, please email us at dash@impro.org. And a big thank you to all the practices that have submitted data thus far. The Governor's Award of Excellence will be awarded in May. It requires a 5% improvement, and if you would like to know the status of your improvement rate or to review your benchmark data, please contact a DASH team member or email dash@impro.org. In recognition of Heart Health Month, our February webinar land will feature stroke survivor Latina Denson's personal testimony. You don't want to miss this opportunity to hear a first-hand account of life before and after a stroke. Today's presenter is Kristian Hurley. Kristian Hurley is the Health Equity Regional Director at the American Heart Association, Southeast Michigan. She manages all multicultural community health programming in the state of Michigan, particularly in Metro Detroit, Flint, and Grand Rapids. She has more than 10 years of experience working in the nonprofit sector and specializes in health education and awareness. In November 2013, Kristian was awarded the Health Strategies Award of Excellence from the American Heart Association's Midwest affiliate, primarily for her work around hypertension education and programming in Detroit. She is a graduate of Case Western Reserve University in Cleveland, Ohio, with a Bachelor of Science in Management and a Bachelor of Arts in Political Science. Today, Kristian will present Check Change Control, a program that began as a pilot in June of 2009 and is now an evidence-based hypertension self-monitoring program for blood pressure control. Please welcome Kristian Hurley.
Hello, everyone. Thank you so much for Impro for inviting me to have the opportunity to talk a little bit about the Check Change Control program from the American Heart Association here in Southeast Michigan. Impro has been a wonderful partner of ours through this process, and so we're really appreciative to be asked. So thank you again for. I'd like to start by just talking a little bit about the mission of the American Heart Association. Our mission is to build healthier lives free of cardiovascular diseases and stroke. It's that single purpose that drives all the work that we do, and I'm sure you know that the need for our work is really beyond question. So in working towards that kind of overriding mission, we've developed something that we call our 2020 goal, which is ultimately to lower death and disability from stroke and cardiovascular disease by 20% by the year 2020 for all Americans. So that caveat of all Americans is where we have found that we are going to face our biggest struggle in reaching that goal. So much of the work that we've been doing in minority communities across the country has been to kind of help us to reach that. How can we make an impact in lowering stroke and cardiovascular disease in minority communities, particularly in African American community and Hispanic community? So what we have decided to do with this program is focus on hypertension, because obviously it is a major issue in the African American community in particular, but if we can make an impact there, we feel like we will really make an impact along all of the risk factors impacting stroke and cardiovascular disease around obesity, sodium intake, physical inactivity, smoking. So it kind of will drive some of these other factors. So how shall I, Capri, am I moving the slides along? How is that working?
You have control
okay.
of the ball, so you can advance the slides as you see fit.
Thank you. Okay. So along with African Americans' increased likelihood of dying from heart disease and stroke, we also find that there's an increase in the incidence of hypertension. African Americans actually have the highest rates of hypertension in the entire world, as well as increased incidence for obesity with a BMI over 30 and a higher sodium diet. We have issues with physical inactivity and ingestion of low fiber and high fat diet, alcohol consumption. So all of these things are adding to that. So some of the things that we took into consideration when developing this program, what we know is that if we can get a 5 millimeter of mercury decrease in systolic blood pressure, this would have a remarkable impact. We found that we would have 14%, advance here, we will have 14% fewer deaths from stroke. We would also see 9% fewer deaths from heart disease and a potential 7% decrease in deaths overall. So as you can imagine, that was staggering. So we thought, how can we impact this? How can we, what kind of programs can we put into place that will truly begin to make an impact in this area? But first we had to address a few other problems. There are several studies that came out that talked about how we found that healthcare providers in some instances don't take ownership of managing hypertension, that there are some issues there, that we have had some, the changes that are coming down the pike to the system will expand the role of nurses and nurse practitioners and physician assistants in the healthcare system. Patients are not adhering to lifestyle change and medication. Patients want to connect with the healthcare provider using digital tools. So looking at those studies, we also, how can we incorporate some of these and address some of these issues? And then looking at the scope of the problem. We know that, there are just millions of untreated patients with high blood pressure. They're either untreated or undertreated, or they might know that they have high blood pressure and it's not controlled. We know that 57 million Americans have hypertension. We know that patients lack understanding of their blood pressure numbers. Many are unaware of the increased risk for heart disease and stroke. And obviously we know, again, in the African American community that this issue is just much more prevalent. We know that 43% of Black men have hypertension and 46% of women have high blood pressure, when you compare that to the 34% of white males and 31% of white females. Compared with whites, high blood pressure develops earlier in life. For African Americans, and average blood pressures are much higher. African Americans with high blood pressure have an 80% higher chance of dying from stroke and 20% higher chance of developing heart disease. We know that this is a chronic condition that requires persistent treatment, and compliance is an ongoing challenge. So just looking at kind of all of these things, impacting the problem have all kind of built into why we felt it was so necessary to be impacting this area. One of the other things that was concerning is that we looked at another study where they were dealing with African American men, and it showed that African American men, as you talked about, have a higher precedence for high blood pressure. But in the same study, over a 5-year period, we saw that their blood pressure actually increased by 29% even while they're being watched and are being monitored for their high blood pressure. 56% of them were actually receiving medications. 30% of them had their I'm sorry, I take that back. Only 30% of them had their blood pressure under control, even though they were aware that they had high blood pressure, and 56% of them were actually taking medication. So, again, adding into this issue of how can we impact this? So it's not just on the side of, physicians that, might not be taking ownership of this problem. Patients have quite a bit to do with this as well. We're finding that patients are not adhering to lifestyle changes and medications that their physicians are prescribing for them. It's the fact that half of the people who try to change a negative health behavior actually relapse and go back to their previous behavior. We know that hypertension patients can sometimes be overwhelmed by the complex lifestyle changes. It's difficult to tell someone, yes, you need to lower your sodium intake, but this might be the only way that this person knows how to cook their food or how to shop at the grocery store. So there needs to be some other external education for that particular patient so that they can learn how to incorporate those better lifestyles in their lives, because otherwise they sometimes feel quite overwhelmed and find that they can't stick to that regimen. As we often say at the American Heart Association, hypertension can be a silent killer. Many people can't feel the symptoms of hypertension. As we've learned from some of our physicians who specialize in this area, that the symptoms can be very obscure. Trouble sleeping, you might be having a headache, but patients don't often associate that with having high blood pressure, and that is also one of the biggest issues that we're facing in this area. There was a video that I was hoping to be able to show you that unfortunately I'm not able to share during the webinar, but one of the things that came out in this testimonial from a patient was that she did not have a family history of high blood pressure. She never really had high blood pressure. So when she randomly had a stroke, she was quite surprised that it turned out that her high blood pressure had been very elevated. So, again, she didn't know that, or she didn't know how to identify those symptoms that were impacting her, and she ultimately did have a stroke. So patients do not feel the side effects of their medications or negative emotions that come with undesirable lifestyle changes is another impact. There's a common misconception that lifestyle changes are enough to help control hypertension and that medication is not needed. So these are all things that we have got to find a way to impact in the community. So going back to the study that indicated that our healthcare providers are not taking ownership of the problem, it was found in an Institute of Medicine study that the issue really is that in some instances, the physician practices are not adhering to the treatment guidelines, which is a significant reason why many patients do not have the condition under control. We're finding that specialists and primary care physicians sometimes disagree on who is primarily responsible for managing hypertension. Our healthcare providers are not taking home blood pressure readings into account when adjusting treatments. And again, these are generalizations and some things that have been found in studies. I know this does not apply to all physician practices, but it is something that is impacting the problem. And healthcare providers are not providing patients with consistent follow-up between visits around their hypertension. So those are the issues that we're facing. Catch up there, sorry. So now that we had all the data, we wanted to look at behavior change and how we could move people along a way of actually making a sustainable lifestyle change. So what are the social influences and the aspiration among top motivators for health behavior change? What are those things that are going to make people take these individual steps that are going to lead them from maybe, not being active, not looking at their sodium intake, all of these kind of small steps that build up to a sustainable change. So we started out with a small pilot. It was called Check It, Change It, And this was kind of one of the first pilots that we did that helped us to develop this check change control program across the country, where we utilized community coaches who are dedicated to helping program participants to succeed by providing support and consistent follow-up. So it was a wonderful opportunity for us to utilize our volunteers in a way. So you find participants who are wanting to make a change, but maybe they just need that one-on-one personal interaction, not necessarily from their doctor, but someone in the community who's trusted, who can kind of help them make sure that they are tracking their blood pressure and staying on top of those things that the doctor has told them they need to be focusing on. Because we know that personal relationships influence health behavior. 43% of people say friends and family have the most impact on their lifestyle as it relates to health, second only to themselves. So people do listen to their friends and family, and so these health coaches from the community can be very effective. We know that positive changes can affect health behavior. Introducing positive reinforcement and upbeat thoughts into daily routines have been shown to help improve medication compliance in hypertensive patients. So from that pilot and us actually utilizing those resources, we were able to start to develop this check change control program. So again, going to the changes to the healthcare system, which will expand our role of nurses and physician assistants. As predicted, this shortage of primary care physicians, as we get all of this influx of people into the healthcare system with our new healthcare law, and combined with our aging population, and as I said, the expansion of health insurance coverage through the healthcare reform, this is expected to put a strain on our nurses and our physician assistants. And they'll be called upon to play a much larger role. But what we're also finding at the same time is that patients want to connect with their physicians using online tools. And we're hoping that this will kind of help to alleviate some of that strain if people can get more done online with their physicians. So in anticipation of these changes and the data that we've discussed, the American Heart Association is developing many new initiatives to specifically address these concerns with the objective to increase our awareness of the connection between hypertension and the risk of heart attack and stroke. Also to increase the number of individuals who are identified with hypertension, and to increase the number of individuals controlling and managing their blood pressure, as well as any behaviors that predispose people to hypertension. So through effective changes in this arena, we are hoping to drive changes in the healthcare system and among patients and our participants. So what we've done is created, from our national organization, 20 markets were identified to utilize the data that we got from our Check and Change pilot that looked at those community health coaches in helping people to deal with their hypertension. And 20 markets were selected to do this program, Detroit being one of them. So we did our first pilot on this program this past year, and so far it has been very successful. It's based on best practice models. It's based on our volunteers working as community health workers and utilizing an online tool called R350, which is kind of a central technology hub for our participants to be able to log their blood pressure. They can track their physical activity. They can put their medications in there to keep track of those. They can interact with their physician through R360. So physician practices can actually join R360 and keep tabs on their patient in between visits, or when the patient is coming in for a visit, the patient can actually print out reports from R360 and take those reports into their physician's office to have them look at them with them to see how they've been doing, say, over the past few months since they've been into the office visit. So it's a powerful tool that was implemented as part of our check change control. We also train, as we talked about, these volunteer health coaches. So we have developed a training program that is very encompassing. We talk to them about, how is blood pressure treated? What is high blood pressure? Who do you need to be targeting to bring into this program? So, if you're a health ministry leader at your church, we help you to identify who are the people in my congregations that need the most help, and how can I reach out to them and bring them into this program. We talk to them about what makes a good coach, what they should be, how they can communicate with these people to most effectively influence their health outcomes. So we have a training program for that. A little more, this kind of gives you an outline of how R350 works. There's a participant portal. They can log in. They can do all of their data input. They can print reports. There's actually an option for them to have text message reminders. So as a part of the Check Change Control program, we can actually set up for them to track their blood pressure twice a month. They have to track their blood pressure twice a month over a period of 4 months. So we can help them to set up something right on their cell phone where they get a text reminder, hey, you haven't tracked your blood pressure this month. If you could please, just enter your blood pressure numbers, and that will be uploaded automatically to R350. So they don't even have to go to their computer. They can do that right through those text reminders. We also provide them e-blast and information and content from the American Heart Association every single week to help them along their way around risk factor reduction, blood pressure, and all of those things that we know are going to help them along the way. There's also a volunteer portal where your health coaches can actually log in and look at those participants that they have recruited. They can see who has tracked their blood pressure, who hasn't tracked their blood pressure, if their blood pressure has been high, so that they know that they need to reach out to that person or make sure that person is seeing a physician. If their blood pressure has spiked or something of that nature, they can actually follow along with that participant online to see what their activity is looking like. So some of the studies that we based our program on, first was the Kaiser Home Blood Pressure Monitoring Study. Participants who use this online tool along with coaching, like our program, by a pharmacist, had a significantly higher rate of blood pressure control at 57% over the usual care group of 37%. So that was very impactful for us, deciding that we wanted to move in the direction of utilizing volunteer health coaches, because we've seen that this can be very effective. There was also the Sprite study, which was a web-based disease management tool that can transform risk factor modification of patients or active participants. The web-based communication coordinated by pharmacist care has been shown to be effective in blood pressure management. So using a web-based tool works, basically, is what we learned from that study, and has helped us to determine what we wanted to use in our program. And then also, again, the Check It, Change It program, where the early results of that pilot have shown a significant increase in controlled hypertension within a highly diverse community. More of the supporting research that goes along with what we're doing. And for those of you who are seeing the Get to Goal at the top, this program has gone through a few name changes, and when we piloted the program last year, it was actually called Get to Goal. So if you're seeing that and you're confused, that is the previous name of our Check Change Control program here in Detroit. So management of hypertension. Hypertension and self-management strategies were associated with better blood pressure management and positive health outcomes. We found that home blood pressure monitoring and telephone administered health coaching significantly improved blood pressure control in another study. We found that use of health mentors could also cause a significant improvement in blood pressure control, and attention to multicultural issues improved self-management, and a randomized controlled trial of African Americans with hypertension was also shown to be very successful. So I wanted to present then, now that we've kind of gone over the program a little bit, what we found from our study. As I said, we did 20 different markets who were doing this 4-month program of having our participants track their blood pressure twice a month over that time. And so the data that I have to share today comes from our national center, and it's composed of the data from all 20 markets. We didn't break it out all across each local market, although I did see some preliminary data that our local market data is also along the same lines. We're obviously seeing a bigger picture with larger sample sizes can better show you how effective this program can be. So we saw in our pilot that lasted from August 2012 to June 2013, we recruited about 30,000 people into this blood pressure program across the country, and with people uploading their data into R350. Our average age for the program was 53 years old, and 75% of our participants were female. Of those participants that shared their ethnicity, 80% were African American. So it was an African American population that we dealt with. So 33% of those participants had high blood pressure. That's under the standards of hypertension being noted as 140 or greater systolic and 90 diastolic. 47% of participants had pre-hypertensive blood pressure, and 20% of participants had normal blood pressure. So for participants who met the retention criteria, being that they uploaded 2 blood pressure readings a month for a period of 4 months, we were actually able to identify that we saw an average drop in systolic of 11.2 millimeters of mercury and an average drop in the diastolic of 4.31. So those are significant drops, especially when you're looking at what we talked about before about the changes that we would see in fewer deaths from stroke as well as cardiovascular disease if we were able to drop these numbers even by 5. For participants who met the criteria of 2 readings per month for 4 consecutive months and started the program with blood pressures over 140 over 90, we saw an average drop in systolic of 27.23 and an average drop in diastolic of 10.52. And this was about 375 participants nationwide that fell into that criteria. Where the first reading was not the last reading, and the last reading was taken at least 7 days after the first reading, we saw an average drop of 5.68 in systolic and an average drop in diastolic of 2.87. So a total drop in systolic blood pressure of 5 millimeters of mercury. So we know then that in dropping that by that 5, we're going to see a 9% reduction in heart disease mortality, 14% reduction in stroke mortality, and a 7% overall reduction in mortality. So just a few tidbits on the Detroit project in particular. We had 466 participants enrolled in our program. Primarily, they were only focused on their blood pressure, as that was what the program was about. But I just wanted to show, if you look there below, this tool, R350, is very powerful in that people can utilize it to track not just their blood pressure, but they were also using it to track their weight, their physical activity, their medication, cholesterol, as well as their glucose. So there were people who decided to go ahead and really utilize this program to its fullest ability and use it to help them to address all of their health behaviors. And we had several people who did do that. We had several partners in our program. Most of them were faith-based. We had 22 different participating sites with churches across the area. We also worked with Brightmoor and Matrix Community Center, Henry Ford Health System, Impro, several community partners. We worked with Gleaners Community Food Banks. They came into the churches and did their Cooking Matters program with people to help them to work on their sodium reduction as well as their healthy eating skills to help impact those hypertension numbers. So it really was a community effort to get folks to really commit to taking those blood pressures twice a month. Those community health coaches were critical in following up with people via telephone, by seeing them at service, making sure they came to the programming and the workshops that we did throughout that 4-month period, making sure that people were uploading their data and really paying attention to those hypertension numbers. And we were able to see significant levels of success with people staying in this country, staying in the program, both in Detroit and across the country. Again, I've already mentioned all of the wonderful partners that we had, the churches. We also worked with the American Cancer Society and Blue Cross Blue Shield of Michigan. So it was a community effort that we were very, very proud of. So that is my overview of check change control and the issues impacting hypertension in the African American community. Do we have any questions that I can address from what we discussed?
Ladies and gentlemen, if you would like to ask a question, please press the number 1 key. Again, if there are any questions at this time, please press the number 1 key on your telephone or type your question into the chat box. There are currently no questions on the phone, ladies.
Okay, we're going to just allow a few minutes in case people think of questions. And if you are able to see the web presentation, there's been an interesting conversation going on in the chat room. Feel free to chime in on that chat as well, and you can do that verbally. You don't have to type in your responses, but we'd like to have a small conversation if possible. We still have some time left for this webinar.
I didn't see the things in chat, so it does look like there was quite a bit of discussion there. Trying to see if there's any questions. One thing I did want to mention is that there has been some changes to the guidelines around hypertension. I mentioned that there have been some studies about physician practices not adhering to them. Those guidelines have actually been changed and updated. And I told Capri that I can make those some links to those changed guidelines available in the resources when this program gets emailed out. Is that okay, Capri? I don't know if that will answer any questions that people might have as well.
Yes, that is no problem. We will post a link to our website, a recording of this, and when I send out that link to your email, I will include the slides that Kristian provides the resources for us. No problem.
Okay.
We do have some polling questions that we'd like for you to answer. It helps us better to gear these webinars for your interest. So if you wouldn't mind, please answer the polling questions before you log out. And I want to take this time to sincerely thank Kristian Hurley for presenting for us today. This is an important program, and going forward in the next few years, the American Heart Association continues their hypertension risk reduction efforts, and IMPRO will be doing the same thing. So we look forward to your continued participation in the Disparities in Cardiac Health program for the rest of this program through the end of July and for future years. As always, if you have any questions or comments, feel free to email dash@impro.org, or you can give one of your DASH team members a telephone call. Thank you, everybody, for attending today's LAN. And if there aren't any further questions, or if there aren't any more conversations going on in the chat, we'd like to conclude this session.
There are no more questions. Ladies and gentlemen, this does conclude your webinar. Oh, I believe we do have one who just came in from Dr. Wentz.
Did we have a question?
Okay, we did have a question from Dr. Stephen Switch. Your line is now open, sir. Please go ahead.
Doctor?
Thank you for the great presentation. I want to talk type TP. She's the greatest. Love her.
Yeah.
You guys are helping us out real good. Thank you. She's helped us with that info stuff. So anybody else on the line help for those for meaningful use, please contact those guys. My question is, and I see that you do get that community involvement regarding getting compliance, and that's one of the major problems we're having, especially with any population, especially the poor, and you did kind of allude to that. Do you guys have access to some names and numbers of community services and stuff?
Community service to provide what?
The outreach type things like the IMPRO people. What we would like is, and if you could work on that, get us some numbers of the community services. You said you have the American Cancer Society and all these other places.
You mean some of the partners that we've been working with?
Exactly.
Absolutely. I can add that. I can add contact information to those who we've been working with. For example, Gleaners is a wonderful community partner. They actually go into churches and do quite a bit in talking to folks about sodium reduction, how to prepare healthier foods. I mean, that's a wonderful resource, and I believe that's a 6-week program, and that's just one program that they offer. They offer, a plethora of things, and so they are wonderful partners and definitely a resource that you could be sharing with your patients. So I can definitely add to the resources that I sent it to free contact for all of the folks that we've been working with to get this program off the ground.
Well, what we need is probably a number that, and I'm so busy, I'm acting crazy. I've been seeing patients while you guys have been talking to, and it's just we need a little thing that we just say, hey, here's a good number, try calling this one.
Yeah, sure. I will put maybe their website as well.
That'd be great.
Just to give you some resource on how to find out what more they can do for your patients.
Thanks. Great presentation. T3, we love you. Thank you.
Thanks so much. Oh, there's another.
Ladies, there are no further questions or comments. Thank you.
Okay, thank you. That concludes today's webinar. We will see you in February for our personal stroke testimony from stroke survivor Latina Denson.
Thank you.